Thank you for joining us for Talking Sleep, a podcast of the American Academy of Sleep Medicine. I'm your host, Dr. Seema Khosla, Medical Director of the North Dakota Center for Sleep in Fargo. Today's episode is sponsored by Axome. The AASM recently released a new clinical practice guideline on inpatient sleep medicine. The task force examined the existing data and came up with some guidance for how to screen for sleep apnea in inpatients, how to prioritize patient groups, determine when and where to perform testing, and how to better engage patients to ensure appropriate outpatient follow-up care. Here with us today are two of the authors, Dr. Reena Mehra and Dr. Dennis Aukley. Dr. Mehra is Division Head of Pulmonary, Critical Care, and Sleep Medicine, and Professor of Medicine at the University of Washington. She is a physician scientist studying the impact of sleep disorders on clinical outcomes. Dr. Aukley is a professor in the Division of Pulmonary, Critical Care, and Sleep Medicine, MetroHealth Medical Center, Case Western Reserve University in Cleveland, Ohio. He does sleep research with a focus on sleep-disordered breathing in inpatients. Welcome. We are happy to have you here today.
Thanks for inviting us.
Thank you.
So, Reena, what was the impetus for these guidelines?
Well, thanks so much for highlighting. I'm a big fan of these podcast series. So, yes, this is an area that has really little attention paid to it in terms of the clinical practice guidelines. And so the American Academy of Sleep Medicine Board of Directors essentially identified that this was an area that we need to focus on a bit more because this is an area of increasing growing concern involving really complex patients that come to the hospital setting. We don't really have any guidance out there in terms of how to handle the approach to these patients in terms of screening, diagnostics, treatment. And there's really a need to kind of synthesize the information out there to provide this guidance.
So, Dennis, do you think there is enough data out there to analyze?
So we looked at several aspects or several questions related to this topic. And for some, we're pleasantly surprised to find that there were some very high quality, well done studies that we could cobble together and analyze. And then some of the questions that we asked, we found there really wasn't much information that either we couldn't make a recommendation or made very low level recommendations on.
Okay, and so this was only for obstructive sleep apnea, right? Or did it include central apnea or obesity hypoventilation?
Initially, we had discussed considering sleep disordered breathing and the umbrella term that it encompasses even beyond obstructive sleep apnea. However, as we started to wade through the data, we really found that most of the data focused on obstructive sleep apnea. So the guideline is really focused on obstructive sleep apnea, not on central sleep apnea, sleep-related hypoventilation. Again, really important sleep disordered breathing entities, however, just focused on obstructive sleep apnea for this guideline.
Okay, so walk me through this. Dennis, tell me about the process.
Well, it's very long, as we found out going through this. So it starts with developing the questions I mentioned earlier. So if the audience is aware of PICO questions, which have to do with patient intervention, comparison, and outcomes. So specifically, what questions do we want answered regarding sleep apnea in inpatients? And so we had to develop those and refine those. And that was, a series of calls just to get through that. That process is then followed by, doing a literature review to see what information is out there, which is also quite an arduous process, going through title, abstract screening, and then manuscript screening. And then we decide on which studies we're going to include for analysis. After that stage, we then do data abstraction, and then we use the grade methodology to analyze the data. And the grade methodology is basically grading the recommendations for assessment, development, and evaluation. And that's a process in and of itself that takes a lot of factors into consideration, not just what the evidence is, but how certain we are about the evidence, what the strength of the recommendations can be based on a variety of factors, including things like harms and benefits, balancing those two, the values and preferences of patients and providers, what's the quality of evidence. We also consider things such as resources, feasibility of what the recommendation would be, as well as health equity. So all those things are discussed in the context of the evidence, and then we come up with recommendations. So it's quite a bit of work, just gathering and analyzing the data, and then sort of trying to put it in the context of real world medicine.
Yeah, I always forget how much work goes into these because, we'll get a document that's, 2 or 3 or 4 pages, and then you kind of forget how many people worked on this and how many hours went into this. And I'm guessing some deliberation, a little back and forth. So we appreciate all of your efforts. So is it okay with you if we just kind of go through the guidelines?
Yeah, that'd be great.
So the article is entitled Evaluation and Management of Obstructive Sleep Apnea in Adults Hospitalized for Medical Care, an AASM clinical practice guideline. So, and I thought this was interesting. It started with a good practice statement. And it said a good practice statement was issued for medically hospitalized adults with an established diagnosis of sleep disordered breathing and on active treatment that existing treatment should be continued rather than withheld unless contraindicated. So I thought it was interesting to open with that. Tell me about that.
I think, yeah, I can take that one. So the idea is that, there really is not a lot of data in this point. And the notion is that folks that already carry a diagnosis of sleep disorder breathing and are on active treatment then are on that treatment because of good reason, either, symptoms or, cardiovascular risk and so forth. And so if they are on that active treatment, then that then would be logical to continue when they get into the inpatient setting. And so should be continued rather than withheld. And this is recognizing, too, that much of the literature points towards a pretty low percentage of patients continuing their CPAP therapy once they are hospitalized, as low in some studies as 5.8%.
Oof.
So, yeah, so it's really, again, even though there wasn't a lot of data, it stands, to be a logical approach to continue whatever treatment they were on as outpatient, particularly in the inpatient setting where they are facing more a higher acuity of their illness and may really benefit from that treatment.
So you say unless contraindicated. So contraindications would be what? Facial trauma, pneumocephalus, that sort of thing?
Yeah, and then there's other reasons, if someone's coming in with intractable vomiting,
Oh,
they've
sure.
had a new injury and they're a high aspiration, a brain injury, high aspiration risk, things along those lines. So they're kind of, I think most of us recognize when we probably should hold the therapy until the patient's maybe in better shape.
Okay, that's fair. That's fair. Okay, so the first one says, and I'm just going to read this right from the guidelines. For medically hospitalized adults at increased risk for obstructive sleep apnea, the AASM suggests in-hospital screening for OSA as part of an evaluation and management pathway that incorporates diagnosis and treatment with positive airway pressure rather than no in-hospital screening. And this was a conditional recommendation, low certainty of evidence. Dennis, tell me about this.
Yeah, so actually, when we were putting this together, and if you look at the papers, we had 3 separate PICO questions here. So one was, what's the value of screening these patients? And then the second one was, what's the value of diagnosing? And then the third was, what's the value of initiating therapy? The problem is that most studies don't really look at these in isolation. And when you think about it logically, it doesn't make sense to screen if you're not going to do anything else based on that, or to diagnose if you're not going to take the next step and do some sort of intervention. And the studies that we found, we actually did find 8 randomized controlled trials that met this criteria, but they all sort of encompass this as a kind of pathway approach where some of the studies did screening. All of them included some sort of diagnostic testing and then initiation of therapy. And we did find that the data was suggestive that you can improve mortality, and we're not talking about specifically in-hospital mortality, but
Oh, you're not.
short-term mortality. Yeah, so
Okay.
post-discharge mortality, as well as reducing new cardiovascular events, and those were clinically meaningful outcomes. We also found some trends in data that looked promising, but they didn't quite meet criteria for meeting clinical recovery or clinically meaningful outcomes in stroke recovery and readmission rates. So as a result of that, so there's data, there's some randomized controlled data. None of these are very large trials. They're often looking at different patient populations with different strategies. So because of concerns, about potential bias and imprecision, the recommendation comes out as a conditional recommendation. But it's a conditional recommendation for doing this with the idea of you're doing this sort of as an overarching protocol or pathway to evaluating and managing these patients.
Reena, any thoughts?
I agree completely. So this was a recommendation, conditional recommendation that ended up being a bit revamped in the setting of recognizing that this is screening occurs in as part of a management pathway. And as far as the approach to screening, we were not very, as you can see, specific about that,
Yeah.
recognizing, that some of these studies used validated screening questionnaires. Others used overnight high resolution pulse oximetry. However, there was not the ability for us to really make any firm recommendations in terms of the approach, and recognizing as well that the focus really, we can't screen everybody. So who do you focus on? And we elected to, in order to be consistent with other American Academy of Sleep Medicine guidelines as well, focus on those signs and symptoms that really would be reflective of moderate to severe degree of obstructive sleep apnea. Specifically, if there's excessive daytime sleepiness, along with a couple more identified factors such as hypertension and snoring, witnessed apneas, and so forth. So we in the guideline is some guidance in terms of which populations to focus on in terms of the screening.
So then the second one is for medically hospitalized adults with newly diagnosed obstructive sleep apnea or with a prior established diagnosis of moderate to severe obstructive sleep apnea, but not currently on treatment. The AASM suggests the use of inpatient treatment with PAP rather than no PAP. And this one also was conditional recommendation, low certainty of evidence. So who wants to take this one?
I can speak to that as well. So with this recommendation, we actually incorporated some of the same studies from the first recommendation, but found some additional studies where it looked like a number of these patients had pre-existing sleep apnea but had not been initiated on therapy. And again, when we put these studies together, and they were all randomized controlled trials, so there ended up being 16 in total.
Oh, wow.
We did find, again, looking at different patient populations and slightly different approaches to how they did the studies, but there did appear to be clinically meaningful improvements in mortality and cardiovascular events, as well as, again, non-clinical meaningful improvements in stroke recovery and readmission rates.
So is this because of the whole 5.8% of people with sleep apnea were treated in the hospital as opposed to the vast majority that were not treated?
I think what Reena was quoting was people that are on PAP have a known diagnosis and generally on PAP therapy as an outpatient, that they're often not getting their PAP when they come into the hospital for whatever reason. There's a large variety of reasons why that may happen.
Oh, I see.
People may not be aware. They may not think it's important. They may not know their
Gotcha.
settings, et cetera.
So this is focusing on people who aren't on treatment at home.
Not on treatment at
Gotcha.
home.
Okay.
Or they may have just been diagnosed during the admission.
Okay.
Yeah.
I was thinking not treated in the hospital, but that makes much more sense. Okay.
Yeah.
Okay. Reena, your thoughts?
Yeah, I think again, I as Dennis said, we did have some randomized controlled trials to point towards in terms of improvement in mortality and cardiovascular events and so forth, with these guidelines and using the methodology, we look at risk of bias as well. And so that is sort of what helped, what kind of drove the conditional recommendation. However, there are these clinical trial data out there. And I think, while we focus on CPAP, we all also know that people are going to be using other treatments, whether obstructive sleep apnea, hypoglossal nerve stimulation, oral appliances, and now more pharmacologics that are coming into the mix in terms of treatment. So those considerations also should be kept in mind. And there might be unique aspects to supporting patients as they're coming in with these different treatments, with GLP-1 agents, for example, with gastric delay and gastric emptying and so forth. So those are some aspects to consider. And, with treatment in the hospital, there what comes with that in terms of positive airway pressure are sometimes differences in, hospital-specific protocols, sometimes, allowing the use of a home positive airway pressure device, and sometimes with biomedical engineering, support, maybe, supporting the home device versus needing to use devices that are provided by the hospital. And then aspects of this also in terms of ensuring that we're doing all that we can to promote as optimal adherence as possible in the hospital setting in terms of using a mask that oftentimes, there has been troubleshooting that's gone into finding the right fit and size of the mask. And so using the home mask versus, the ones that are offered in the hospital, which sometimes, is just not as comfortable for the patient.
Yeah. Yeah, I think we've all kind of had a bad experience trying to introduce CPAP to somebody in the hospital for the first time. So that there's a lot of art in that, isn't there?
Yes, it can be very tricky.
So that takes us to the third one. For medically hospitalized adults at increased risk for or with an established diagnosis of obstructive sleep apnea, the AASM suggests that sleep medicine consultation be available as part of an evaluation and management pathway rather than no sleep medicine consultation. And this is a conditional recommendation, very low certainty of evidence. Dennis, this sounds like your area.
Well, so I have started I think maybe we'll talk about this a little more later, but more of a proactive, sort of what I call a proactive sleep consultation service at our hospital in the past several months. But it seems to make sense that, if we're going to have these type of pathways or protocols in the hospital, that really you need someone in sleep medicine with that expertise sort of overseeing the process. And I think we put in there, it really should be, the board certified or provider or an ASM accredited center that's helping to run whatever protocol you decide to come up with. There wasn't a whole lot of data looking at this. There's primarily one pretty large observational study, which reported on some outcomes in terms of facilitating getting patients diagnosed, which is important. That's part of the reason that this whole idea came about, is because so many of these patients are undiagnosed and keep being readmitted, and someone needs to finally make the diagnosis. And but I think in order to make this work, you really do need someone with that expertise. Now, it can be, it doesn't necessarily mean that, the sleep consult has to be your, like you think about in terms of a traditional consult service where you have, the attending, and if you're at an academic institution, the house staff, and, you're running around and seeing these consults. It may be something where you have a protocol in place where patients are being identified, and then you have a sleep navigator or a coordinator, being overseen by a sleep physician, that can at least get these patients plugged in, get them in a pathway. So there's a variety in both documents, the systematic review and the CPG, the clinical practice guideline. We do discuss a lot of sort of different models that you can consider depending upon what your local infrastructure and resources are, because we realize that, throwing out a full formal sleep consultation service may not be feasible for many institutions, or in private practice, whatnot. So trying to at least get people thinking about this, how this can work for them locally, and whether that's something that's, like I said, is a full-scale consult service or something that's identifying these patients and getting them plugged in with a lot of support personnel, more of a team approach.
I love the
Mhm.
idea of an inpatient sleep consult service. I think that'd be fantastic, right? Because you could grow it, and you could talk about like the sleep environment, and maybe don't wake them up in the middle of the night for MRI. And I just feel like we could, if they would allow us to unleash all of our sleep knowledge on the
Oh,
inpatient service.
yeah, so you could go a lot of ways with it. And it will grow very quickly if you're not careful.
And then what about number 4, Reena? This one says for medically hospitalized adults at increased risk for or with an established diagnosis of obstructive sleep apnea, the AASM suggests a discharge management plan to ensure timely diagnosis and effective management of obstructive sleep apnea rather than no plan. And this one again, conditional recommendation, very low certainty of evidence.
Yes, so this is really an important part of the pathway because, we know that if patients screen positive, or if even if we are able to establish a diagnosis in the inpatient setting and get them started on treatment, the follow-up is so incredibly important to ensure that they either are followed up if they were diagnosed to start treatment, or if they're on treatment to continue the treatment, and to ensure that we're doing all that we can to optimize their adherence. So this, again, not a lot of strong evidence to support the recommendation. However, enough evidence to make it a conditional recommendation in terms of this post-discharge follow-up. And the data really do point towards a fair amount of folks not having that follow-up that's needed in the post-discharge setting. And there's various ways that have been studied in terms of how to make that happen in a more seamless fashion. Some of the work being done by some of my colleagues to look specifically in the heart failure population, for example, and using telemedicine strategies to make it easier for the patient to connect after they're discharged, to ensure that they're getting started appropriately on treatment, and optimizing adherence, and using even strategies like motivational enhancement and so forth.
You talked about something earlier about mask fit and biomed. And so I think what you're really talking about is like operationalizing these and these sort of inpatient PAP considerations. Tell me about this. Like, do you have, because I imagine this is multi-pronged, right? Like you'd have to work with the biomed guys, and you'd have to have appropriate mask selection and train your RTs, and sort of have this team approach to it. So what advice do you have? Like, tell me about these things we should be thinking about.
It's this is a really important area, and I think that kind of gets back to your sleep medicine consultation service. And at the Cleveland Clinic, there's one that was started. It was called the Dream Team, to make it catchy and to allow make it fun. People will remember it, and it's front of mind in terms of we can call the Dream Team for support. You're right. I think we have to pay attention to maybe, specific pathways, what kind of support we can have in place to really ensure, especially that first-time exposure to CPAP is a positive one. And for those that are coming who are already on therapy, that we're helping them, right? Because and making sure that they're using a mask that they're comfortable with and they're familiar with. So, and oftentimes we don't have those resources in the hospital setting. So one of the, I think, exciting aspects of this guideline is that, not only is there some, conditional guidance being provided, but I think it hopefully will really put more front and center the need for paying attention to obstructive sleep apnea in the inpatient setting, And so that we start now to have some of these processes in place where, like you said, who's going to be responsible for ensuring that the patient has the right mask? How do we make sure that we're appropriately resourced in the hospital setting? And there, as Dennis mentioned before with the inpatient sleep medicine consultation, it's just so variable in terms of the resources and supports that institutions have across the board.
So let's take a short break, and when we come back, we'll talk more about the new AASM inpatient sleep medicine guidelines. You're listening to Talking Sleep from the American Academy of Sleep Medicine. Welcome back to Talking Sleep. We're talking with Dr. Mehra and Dr. Aukley about the new AASM inpatient sleep medicine guidelines. So, Dennis, you hinted at this earlier, but I would love to learn more from you. And I'm thinking about these really practical considerations. Like, you kind of say screen patients for sleep apnea. Like, what does that mean? Is this stopping, or is it sort of you guys decide what you want to do at your institution? Like, how does that work?
Yeah. So as I mentioned, I've been doing one here at our institution,
Yeah.
but knowing colleagues around the country that have implemented sleep consultation services at their own institutions. If you take one of ours, they're all going to be, compared to the others, they're all going to be different. So it all just really depends upon, again, we talked about resources, infrastructure, things of that nature. So in terms of, screening, first off, I think most of the time people are going to find it easiest to do some sort of questionnaire screening.
Okay.
Which probably, if you really want to make it happen and that make it a reliable system, it needs to be out of the hand of the physician and probably should be in the hand of,
Yeah.
probably nursing. Someplace I think use RT, or there's even, electronic medical record screening if you're so inclined, depending on how large you want to roll out your pathway. In the questionnaires, some have some validation for the inpatient setting and some for specific patient populations. For instance, I know there's been some modifications of the stop bang questionnaire for patients who've had a stroke to try and improve its accuracy. So there's a variety of different questionnaires that can be utilized. I think it just depends upon what might be easiest to do. We found at our institution doing the stop bang, we can put it in a flow sheet in our electronic medical record. The nurses can kind of click through it. And that gives us the information that we need fairly quickly, as long as it's routinely done.
How do you get the neck circumference?
That is actually one of the sticking points of the stop bang. So most of the time it does get done, but we have, and this gets to sort of when you implement these sort of pathways and protocols in the real world, you kind of need to seek feedback and be flexible and work as a team. So that we've been doing the stop bang, and that is one of the sticking points, is just ensuring consistently getting the neck circumference, because that can make a big difference, right? If you're between intermediate and high risk, and maybe that's going to impact what your next step is, you need that information. So I found, I've often will be following up with nurses about, hey, would you mind getting this when you get a chance? And most of the time it will happen. Some of the other questionnaires you could utilize that don't require that, but they also have their own issues in terms of just being easily used in an inpatient setting.
Yeah, that's always the hardest, right? The neck circumference, like even outpatient, people write in like large, something like that. But then do you remember that paper where they did the stop bag?
Right.
Yeah.
Yep.
Yeah, at the Cleveland Clinic, I think that was where it was looked at in terms of using the instrument without the neck circumference and how it sort of functioned in the stroke population. And they were in the way that they were able to weight the different factors to then still be able to use it in a meaningful way without the neck circumference, I think was meaningful. Now, how that does in other populations, I think needs to be further investigated. And I agree. I think, the way Dennis is describing leveraging the EMR to make it easier for screening is also something to really pay attention to, because a lot of times, like the body mass index or other aspects of what's included there, hypertension as a comorbidity, can be kind of automatically, inputted into the stop bang and sort of make it easier for folks to calculate. And sometimes you reach high pretest probability, probably even without
Yeah,
that circumference.
Oh, could I just emphasize one point on that
of course.
study that Reena was mentioning? I love that study, and I think this also points to one of the areas where you would wonder about generalizability in terms of using it beyond the stroke patient population. As we know from a number of other studies, patients who've had a stroke and are found to have sleep apnea, that their body mass index on average is much, much lower. Many of them are
Mm-hmm.
not obese.
Mm-hmm.
And so it may be that the neck circumference, doesn't really
Doesn't
play
matter. Yeah.
much of a role in
Yeah.
screening for these folks. And so I think that's a great example of, someone thinking this through, oh, we can probably, alter this tool and utilize it in this specific patient population.
So who needs to be screened? Is this like everyone that rolls through the door or certain areas, or how do you do that?
We tried to provide some guidance in terms of the screening as far as symptoms and comorbidities, and also recognize, even with the inpatient sleep medicine consultation aspect of this, as we're talking about implementing some of this, that there's going to be again, variability in what you have available. And maybe this is something that you're just starting up, and if that's the case, how do you even go about this? And what may be very reasonable is to, again, focus on those who are sleepy or have cardiovascular comorbidity, and also perhaps even those populations that are at highest risk, like the heart failure population, or as we were talking about, the stroke population. So perhaps, even piloting it in one of those patient populations, and then implementing your screening in that kind of population, and then taking it and scaling it up from there.
And yeah, I'd like to add on to that, a lot of the randomized controlled trials that were done in cardiovascular or post-stroke
Mm,
patient populations. And those are really, I kind of consider them the low-hanging fruit, right? So the prevalence rates of sleep apnea is going to be very high in those patient populations. Most are not going to have been diagnosed, and probably the impact of, diagnosing and intervening in some form or fashion is probably going to get you your biggest bang for your buck. So I agree with Reno. If you certainly don't want to roll out system wide. I don't think the
mm.
gist was to let's find everybody with mild sleep apnea in the hospital, because you will never go home if you do
Oh my
that.
gosh, yeah.
But we want to look for where is this going to have the highest impact, I think, based on the information we have and what seems to make sense.
And I noticed that in all of the recommendations, it was very specific about hospitalized for a medical thing, right? So this is not the ortho ward, right? This is not the post-op patient. This is someone hospitalized for a medical thing.
Correct. Yeah, there's
Okay.
a whole separate body of literature
Mm-hmm.
regarding perioperative obstructive sleep apnea, having to do with screening and management. And there are already published guidelines from both the ASA and the Society of Anesthesia and Sleep Medicine on those. And we thought it would be best not to try and tackle that, given you know,
Yeah,
we
that's
had
fair.
plenty on our plate with this topic.
Well, you sort of tongue in cheek said that the screening should be done by someone who's not a physician. And you sort of threw out nursing and you threw out sleep navigator. And Rena, you talked about like the EMR and you kind of utilize the EMR to really help scale this. So I guess what I'm kind of wondering is then it probably wouldn't be a hospitalist that would do the screening. Because that's where I kind of went, that maybe it's the hospitalists that would start screening for sleep apnea.
You're
But that's
right.
not.
I mean, I think you're right, because the inpatient sleep medicine consultation will come later,
Mm,
and then the screening is going to happen obviously before that. So, yeah, I think you're absolutely right. So making that, um, getting that front and center on in terms of what people are thinking, which is hard to do, right? Because
hmm
patients are hospitalized, you're focused on the reason why they're hospitalized, even though obstructive sleep apnea may be a very important risk factor for some of the very reasons why people are in the hospital. So I think, when I'm on doing rounds, for instance, I always, meet with the residents and really try to emphasize the importance, and let them know about the pathways and the consultation service that's available to support. Uh,
Mm.
But you're right. I think there's so many different ways to do this. And I think especially the recommendation for the sleep medicine consultation was the one we stewed the most about, because we just know that it's going to be difficult for some institutions and places that may not have as much in the way of personnel and resources. And so, again, though, I think this allows us to sort of break that barrier a bit in terms of recognizing that this is something that we really should be paying attention.
Yeah, and I think, when we were preparing for this, Dennis, you kind of talked about somebody who, maybe you don't catch them the first time, but they come back over and over with decompensated heart failure or COPD or something like that. So at some point, you hopefully eventually capture that they have sleep apnea and then treat them. And maybe does that allow them to stay out of the hospital longer?
Yeah, exactly. I think that's part of the reason, this whole thing was launched was, as Reena mentioned, when I'm on rounds, they'll start presenting a patient. It'll be a 65-year-old male with paroxysmal AFib and uncontrolled hypertension and FPEP, and there's never any mention of sleep apnea. I'm like, wait a minute.
But it's in there.
This
It's
guy's
in
got
there
it,
with that
yeah.
list.
And these aren't, they've had these problems for years, and
Yeah.
they haven't been diagnosed. And so maybe this is our opportunity now to get them captured and get them the care that they need with as you mentioned, the goal really of trying to improve, their quality of life, but also, hoping to help with their long-term medical conditions and prevent those readmissions.
So in listening to both of you speak, I've just been thinking about how education is this huge part of this. And I think both of you have kind of mentioned that you are actively teaching residents and fellows and medical students. Does the education extend beyond that?
It's a good question. I think, there are so many opportunities to connect with our nursing colleagues, respiratory therapists in the hospital, and even our colleagues in other disciplines to really, increase awareness, which I think is happening. But I think we could always use more of that in terms of connecting and emphasizing the importance. And things like a consultation service in the inpatient setting in of itself, the more that people refer and people think, people will be thinking about it, I think will then also really help in terms of the awareness, I guess, and then along with that education.
Yeah, and I would echo that. I sort of think about this, I think many of us do, as sort of a team approach to it, that you're not going to be able to do this by yourself or just with sleep medicine. You really need, all your nursing RT, your DME company, your colleagues in other specialties. You really need them on board to make this some sort of pathway or protocol work. And they need to be educated and understand the importance of why this should be done.
And I imagine that patient education is huge, right, for that engagement? Because I'm imagining somebody that's in the hospital, they don't feel great. They're in with like CHF exacerbation, and then their meds get changed, and then they get weighed, and they have dietary changes. And probably the last thing on their mind is, oh, by the way, you also need a sleep study. Because I imagine that just becomes deprioritized. And so at some point, like, how do you engage them enough to get them to follow up outpatient?
Yeah, that's extremely important. I would definitely agree with that. It does, the patients, as you mentioned, coming in often a lot of other things on their mind, and they're dealing with other issues. But I've found, in my experience of doing this for a little while now, that almost all the patients, there's some exceptions, but most are receptive to hearing about it. Most are willing to undergo, evaluation. There are some that, as you mentioned, say, I just can't deal with this right now. I'll address it later, hopefully. But in those situations, at least they are aware of it now. It's been discussed with them. But you do need somebody that's again, who that's going to be, may depend upon what your resources and infrastructure are. But you need somebody that's informing the patients, educating them. This is what it is. This is what we can do to evaluate to help you out. so that they have an understanding of it. I think if you just screen and say, hey, you might have sleep apnea and kind of leave it at that, nothing will happen. They won't come back.
Well, but I think that's something really important that you've hit on, right? That it's one thing to screen and to maybe send them a leaflet or, talk to them a little bit about sleep apnea, but unless you engage with maybe that is the role of the inpatient sleep consult. And if that is a sleep navigator or whatever that looks like, maybe that is part of the secret sauce to engage them and have them follow up.
The engagement piece is just so important. And I
Yeah.
think, really driving home the why, because a lot of folks may have heard about obstructive sleep apnea, but may not understand how that sort of links into their cardiovascular status or neurologic status. And if you kind of can frame it that, hey, identifying, treating obstructive sleep apnea may actually help, may actually, reduce your likelihood of coming back to the hospital, kind of framing it in that way can be effective. And I think, as Dennis said, it's so important to engage with our key stakeholders around us. So, for instance, if you have a patient with heart failure, engaging with the cardiologist and having the cardiologist also being a spokesperson for this, because they may already have a relationship with the patient, have that trust built up there. So, leveraging those relationships to really have the patient hear this from more than just the sleep specialist.
Yeah, I would totally echo that and agree. If you have the nurse telling you, hey, you might have sleep apnea, this is a problem, and then a doctor comes in and tells you, hey, you might have sleep apnea, and the respiratory therapist comes in and tell you, I think they're going to start to get a message that this is an important problem. So if you can really, have sort of that almost 360-degree, education going on, I think that'll make a huge difference.
Well, and I feel like linking it to whatever they're in for is part of that sort of aha moment. Because I think in our field, we have always sort of been accused of, you go into a sleep center on one end and everyone leaves with a CPAP, right? And it feels like it at least makes it more personalized, more meaningful than, just rolling out to CPAP. So I love that. So it sounds like you kind of need a champion, though, to create a program like this.
Oh, you really do. It's generally not going to be a small undertaking.
Okay.
You need, as I mentioned earlier, you really do need to engage your colleagues, a number of individuals in different areas, including your administration, DME, and all that. And then just even if you get something, it has to be thought through how you're going to do things from a logistical standpoint. And then once it's implemented real world, getting feedback, making adjustments, whatnot. But none of that's going to happen unless somebody is really, carrying the flag forward, saying this is important. We need to keep working on this. I think if you leave it just to, okay, we're going to screen and you guys do this protocol and no one's really keeping an eye on it or following up on it, it won't work.
So I am really interested in learning from your experience. Dennis, you talked about how you created this sleep program, a while ago. What do you wish you had known before you'd started?
I think, there's a number of things, some of which I spoke to already. Just, it will take some time up front. You really have to put some time into thinking about it and what you can do feasibly at your own institution. There is a strong education piece, as we already mentioned. There needs to be some patience as you do begin to implement whatever protocol you are going to use, because it's going to be a change, and it's a change in behavior in people is difficult, and so you're trying to enact that. And then be willing to accept feedback based on how things are going. Maybe you have this great idea and this pie in the sky idea how you're going to do this, and it doesn't work for your colleagues or other people. So you may have to make some adjustments and be willing to be flexible, and figure out what's going to be successful at your own facility.
And maybe start small.
Start small. Yes, definitely agree with that. Start in an area where you think you can keep an eye on things, and then as once you get things smoothed out, all the bumps in the road, the hurdles overcome, then you can begin to roll it out.
So Reena, you hit on something that I find incredibly frustrating. It's, because I do outpatient sleep medicine, And so when a patient is going to have like surgery or whatever the thing is, and they have their CPAP equipment and they bring it into the hospital and like no one sets it up, no one plugs it in, no one knows it's there, they never get treated. Like, I find it so frustrating. So I'm hoping to learn from you. How do we make that better?
Oh, well, I think we've all faced this, right? The patient sitting there and their CPAP device is in the corner, and no one has taken the time to sort of even take it out of its case and set it up. And so, yes, this happens a lot. I I don't know that I have any major insights other than just obviously I think it's just the education, just making sure the importance of treating sleep apnea is kind of on the forefront of what people are thinking about. Um, and educating the patient and engaging with our colleagues, our respiratory therapists to help with setting it up, and it's just making sure that the nurses, uh, the learners on the team, everyone is aware just of the importance.
Okay, throw in a little anecdote here.
Please, yes.
So as you know, I've been rolling out this process at our institution and some colleagues involved, and so the inpatient providers see us running around the hospital. We're not quite the dream team, but we're the sleep team, and so they're they're interested and they are hearing about it, and so I've started to notice that they are picking up on this and paying a little more attention. And just last week, I was looking through a patient's record who was admitted, and in the resident's note it said, "Patient has a hypoglossal nerve stimulator at home. We'll have family bring in remote." And I was like, yes.
That's amazing.
Yeah. So it's I think 6 months ago they probably wouldn't have known what to do. Um, and so I think just the presence of being there, being on the floors, having people talk about it, I think it is starting to slowly sort of change the thoughts and how people are approaching this.
So what happens then? Like, does somebody need to bless that like they would for a CPAP, or is it just you just turn it on and go?
Well, that's a good question. But that's something that if it depends on really why the person's in. I can't remember why this person was specifically admitted, but in terms of if you want to reassess, obviously you're not going to do probably a full sleep study on someone in the hospital to check their hypoglossal nerve stimulator, but there are other things, you can assess their symptoms. You could do some simple oximetry or a home test if there was concern that things weren't under control.
Yeah, because there was a
But
process, right, for the biomed guy to come sort of bless the CPAP and make sure it's
yeah,
okay.
yeah.
So I've never even considered what you would do for a hypoglossal nerve stimulator.
I think they probably don't need to be involved with that since it's implanted in the patient.
Yeah,
I guess it's kind of like coming in with a pacemaker.
pacemaker. Yeah.
Yeah.
It brings up a good question, though, in terms of even just settings of these devices, like even with positive airway pressure. Do you use their home settings and that their physiology might have changed in the hospital? Do you have to adjust that? Maybe they need concomitant supplemental oxygen in addition to the positive airway pressure. So there are all of these other aspects to consider too.
Yeah, because every so often somebody will come back to clinic and they're on oxygen, and I'll be like, "Why are you on oxygen?" "Oh, I was in the hospital, and the thing kept going off all night." And then I'm like, "Well, were you wearing your CPAP?" And invariably, it's no.
Yeah.
And so then somebody did an overnight oximetry, they're hypoxic, they get set up on oxygen, and no one ever plugs in their CPAP. And so then we kind of have to rewind that a little bit outpatient, I think.
Yeah.
Yeah. So let me toss this out at you. Is there a legal liability for someone who has known obstructive sleep apnea but just wasn't treated in the hospital?
I'm going to throw that to the lawyers. No, my own personal opinion is that I don't think so. That again, this is the first guideline coming out. There has been no real precedent set for this before, and our recommendations are all conditional. So I think, I think from a legal standpoint, you can argue your ways all around that in terms of um, how you want to uh, look at it. But I don't think we're at that point yet where we could say that there is. But that's my own personal opinion.
Reena, your thoughts?
I would agree with Dennis. I'm not sure that there would be legal ramifications. I think, again, this is the first inaugural guideline to really provide some, um, you know, albeit conditional recommendations about how to handle things in the hospital setting in terms of suspected or established obstructive sleep apnea. So I would leave it to the lawyers as well. I agree with you.
And there's all sorts of, complexity and nuances for any individual case that I think it becomes very hard to say there's any kind of, standard.
I do love, though, that sleep is finding its way into the hospital. When my dad was hospitalized probably 10 years ago, he had a little kit that had like earplugs and a mask and like just sort of these little things that kind of allowed you to feel like they were prioritizing sleep, for better healing and so on and so forth. So I was reassured to see that, and that was quite a while ago. So tell me, any final thoughts or take-home messages for us, Dennis?
I guess just a couple of quick thoughts. I think part of this guideline is just to sort of get people thinking about this, get it on the radar that sleep medicine is no longer just an outpatient specialty. We really need to be thinking about it in the hospital. And I think it is reasonable for folks to start thinking about how they can develop some sort of, pathway or protocol to implement at their own institution. And it's going to require some planning and some careful thought. Start small, like we talked about, then be flexible.
Reena, you want to bring it home for us?
Sure. No, I completely agree. I mean, I think our specialty is really focused on the outpatient setting, and this is an area that I think all of us have faced in terms of obstructive sleep apnea, how to approach things in the inpatient setting. So it's our first foray at trying to provide some guidance in that realm. And for those institutions or places that really don't have anything in place, then it allows them to start thinking about what they can do to address this. And I think also as we've gone through the data, although as we reviewed, there were some randomized controlled trials. I think we need better quality studies, more larger multi-center randomized trials to generate some higher level evidence that hopefully the next time the guideline is written or updated, we'll have more backing regarding some of these recommendations, and even cost-effective analysis, and also how to handle other sleep disorders in the inpatient setting.
Well, thank you both for joining us today and for going through the new AASM guidelines for the evaluation and management of obstructive sleep apnea in adults hospitalized for medical care. I do really appreciate you guys allowing us a peek behind the curtain and for sharing your experience with us so we can be better prepared in the event that we want to create a sleep apnea program for inpatients.
Thanks for shining a spotlight on this important area.
Yeah, we do really appreciate it. And thanks for having us. That was a lot of fun.
Thanks for listening to Talking Sleep, brought to you by the American Academy of Sleep Medicine. For more podcast episodes, please visit our website at aasm.org. You can also subscribe through your favorite podcast service. And if you enjoyed this episode, please take a moment to leave a rating or review. For more feedback or suggestions, email us at podcast@aasm.org. I hope you'll join us again for more Talking Sleep. Until next time, this is Seema Khosla, encouraging you to sleep well so you can live well.